Good morning, good afternoon, and good evening to all the speakers, chairs, and the wonderful audiences in different parts of the world. Welcome back to another episode of ACNS webinars. The speaker for the first session of today's webinar is our honored guest from Nepal, Professor Amit Thapa. Professor Thapa is the professor and head of Department of Neurosurgery at the Kathmandu Medical College Teaching Hospital, Sinamangal, Nepal. His clinical interests are focused upon cerebrovascular surgery, spine surgery, traumatic brain injury, and epilepsy surgery. He is the vice president of the Nepali Society of Neurosurgeons and Nepal Epilepsy Society. He is also the chairperson of the spine section of Nepali Society of Neurosurgeons. He is a noted author with several publications in various peer-reviewed journals. He is editor-in-chief of the Nepal Journal of Neurosciences and also serves on the editorial board of the Journal of Kathmandu Medical College, Annals of Neurological Surgery, as well as the Stroke Journal. We are extremely honored to have him today at our webinars, and today he'll be talking about clip reconstruction of cerebral aneurysms, what, when, and how. The speaker for the second session of today is our honored guest from China, Professor Duan Lian. Professor Lian serves as the professor and chief physician of the Neurosurgery Department of Neurosurgery in the Chinese PLA General Hospital and Chinese PLA Medical School. He was awarded professional and special government allowances of the State Council. He has conducted over 9,800 cases of intracranial and extracranial revascularization for Moyamoya disease to date. He has 166 publications, 45 of which are SCI journals such as in stroke. He is also involved in 14 research projects, including project of the National Natural Science Foundation of China, major project of the Beijing First Round Fund, and National Key Research and Development Program. We are extremely honored to have him today as a speaker at our webinars, and today we'll be talking about indirect revascularization in Moyamoya disease. The chair for the first session of today is our distinguished faculty from Japan, Professor Hidehito Kimura. Professor Kimura is an associate professor of neurosurgery at the Kobe University Graduate School of Medicine, Kobe, Japan. His clinical interests are focused upon cerebrovascular neurosurgery. He is an integral part of the Japanese Neurosurgery Association, and he has done phenomenal work on computational fluid dynamics of cerebral aneurysms. We are extremely thankful to Professor Kimura for accepting our invitation to chair the session of Professor Amit Thapa. The chair for the second session of today is our distinguished faculty from China, Professor Shubin. Professor Shubin is the vice president of the ACNS and is a consultant neurosurgeon at the Huashan Hospital, Fudan University, Shanghai, China. His clinical interests are focused on cerebrovascular neurosurgery, and he has the largest number of bypasses for Moyamoya disease in this world. His literary contribution sums up in scores of publications and book chapters, and he has been a cornerstone of these webinars ever since we started broadcasting them. We are extremely thankful to him for accepting our invitation to chair the session of Professor Duan Lian. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I'd like to welcome all the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely thankful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Libun Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over this podium to our first chair, Professor Hidehito Kimura.
Thank you, Raja, for your kind introduction. Hello, everyone, and good evening. I'm Hidehito Kimura, Kobe University from Japan. It's a great honor for me to chair the first session, and I also thank you, ACN's President Yoko Kato, Professor Yoko Kato, and our board speakers, and Professor Shubin and Professor Liu Gunsen. Nice to see you again. And I'm very glad to introduce the first speaker, Professor Amit Thapa from Nepal. He will talk about the clip reconstruction of aneurysm, what, when, and how. I have been looking forward to hearing your presentation. So Professor Amit Thapa, please start your presentation when you're ready. Thank you for joining us.
Thank you, Professor Kimura, for a nice introduction. At the outset, let me thank ACNS, Professor Yoko Kato, and Dr. Raja for a kind invitation. When I received the invitation, I was thinking as to what to speak. And then we thought, why not to talk on the clip reconstruction of aneurysm? When we were residents, then we used to discuss a lot on these particular things. But then slowly, as the coiling has started taken up, however, this clip reconstruction of the aneurysm becomes only restricted to very much complicated cases. And that's why we thought, why not to talk on this issue? So below are the glimpses of the places of work in which I'm associated, Kathmandu Medical College, and have nothing significant related to this talk. So the aneurysm clipping started in 1937 with Walter Dandy clipping the first aneurysm. And since then, it has become a gold standard. However, with the advent of coiling and endovascular techniques in 1990s, with the introduction of a stent as well as fluid diverters and pipeline embolization, we see a major transition as to how this aneurysms are dealt with presently. Still, for the complex aneurysm, clipping is still considered a gold standard. But the clip reconstruction is difficult and requires careful planning and execution, which I am going to talk in my subsequent slides. So when we talk of clips, we should also talk of what is clipology, or what do you mean by clips as such. So ideal clip is supposed to achieve an adequate clipping pressure to occlude the blood flow inside the aneurysm, however, preserve the vessel by maintaining its patency. So there has to be a constant clipping pressure without any displacement or slipping with time. We need to use the smallest size possible so as that the neck is completely occluded. And material slowly is much more getting advanced, with the non-magnetic and low density being used without any interferences with CT and MRI with the recent advent of technologies. Its smooth surfaces and absent edges are, yes, always to be seen. Surface free from the crack should always be assured before we use these cracks, and proper jaw alignment, which tends to shear the vascular tissue between the jaws, has to be assured. Now, this particular problem comes when we are sterilizing the clips for many number of times. So this has to be checked before we apply. And of course, when applying, we need to check that the clip is not getting obstructed in the surgeon's view during the implantation. Now, there are various types of clip one uses, which can be broadly categorized either temporary or permanent. By temporary, we mean that the clip needs to be removed. And this is usually applied to just occlude the flow inside the vessel for some time once the aneurysm is clipped, and after that it is removed. Permanent clips are supposed to be left onto the operative field, and it completely occludes the blood flow inside the aneurysm clip. Now, these are called temporary and permanent depending upon the occluding pressure it applies over the vessels. So usually it has been studied that the temporary clips applies a closing pressure of 70 G, which is corresponding to 0.69 Newton, as compared to permanent clips, which varies from 130 to 160 G, also in Newton, it is 1.27 to 1.6 Newtons. Now, there are many sizes in which aneurysms clips appear in. Now, it can be standard, mini, or extra long sizes. And also, there are many configuration these clips are made, either straight, curved forward, backward, sideward, bent forward, backward, sideward, or even bayoneted and fenestrated. Now, over the period, clips have evolved from the Cushing's malleable silver clip, which was first being used but could not be remodulated, to the spring ones, which can be opened and reapplied in later. So different types of opening and closure mechanisms have been devised, from UV type to pivot, mobile fulcrum, and nowadays alpha type clips. And these days there are 4 major clips which are being used: McFarland variangle, soon slipline, Sujita, and Yasagal. In our part of the world, it is the Yasagal clips which are being used most often. Now, when we talk of reconstruction of aneurysm, we mean to see that we are closing the neck of the aneurysm permanently, however, trying to preserve all the branches which are coming out of those the neck or from the sac, as well as preserving all the parent and the efferent branches. Now, this has to undertake through 4 different processes. The first is the planning. The second is the preparatory step. The third is the execution, and fourth is the evaluation after we apply the clip. Now, planning always starts with a careful evaluation of the imaging, where we have to understand the correct location of the aneurysm, the size, the shape, which can be a presumptive area from where the aneurysm might have ruptured. Usually it is the fundus which ruptures the most. And then the neck of the aneurysm needs to be identified. Now, the importance of neck is that usually the neck, when measured, can give you the approximate size of the clip we are going to use. So usually the clip is 1.5 times the neck size. So that actually helps you to pre-decide as to what the clip type of clip you are going to use. Of course, we also have to read the perforators or the branches which may be emanating from that area. And we also have to rule out any other aneurysms, because that needs to be planned beforehand. However, all the CT angiographies or the DSAs can still miss it, and henceforth we need to check the surrounding areas when we are exploring the aneurysm completely. And of course, we have to make some preoperative plans, strategies to how to decrease the intracranial pressure, either by draining the CSF preoperatively or intraoperatively. Then we have to make a plan regarding the proximal or distal control, which may be required, particularly in cases of a ruptured aneurysm, where the risk of intraoperative rupture is fairly high as compared to the unruptured one. Rotten's rule also helps a lot, which I will be discussing in further detail. And then we have to have a stock of the aneurysm clips. Now, this particular flow actually tells us how we can actually plan the aneurysm, and we can work upon this in our in our imagination, in our 3D concept when we are trying to plan such surgery. So nowadays, navigation is a very helpful platform, which is available in most of the neurosurgical centers. So what we do is we actually get the 3D of the CT angiography films or the DSA on our navigation platform, and we like to play it on all the planes and try to see not only the morphology of the aneurysm, but also its proximity to the different bony landmarks, which can help us identify what type of craniotomy and how much of drilling would be required. So this particular platform actually helps us to make an idea about our surgical procedure way before when we actually go into the procedure itself. Then comes the 3D fabricating of the aneurysm. Now, this was published in one of the Chinese journals by the Chinese authors, and then they have actually used the 3D technique of printing the aneurysm inside the head and trying to clip it using the aneurysm clip applier. And this actually gives a very good method of teaching residents as to how the aneurysm would actually look like inside the brain and how you can do the aneurysm clipping before coming to an actual patient. Now, Rottel's rule actually helps us to identify as to how or which orientation the clip needs to be applied. So the 4 rules which Rotten has described, the number 1 is aneurysm arises at the branching sites of the parent artery, which may be the side branch of the bifurcation. Henceforth, the clip needs to be applied perpendicular to the afferent artery and parallel to the efferent branches. Now, this holds true whenever we're talking of an MCA bifurcation aneurysm or a basilar bifurcation aneurysm. Now, other 2 rules, rule number 2 and rule number 3, aneurysms arise at turns or curves in the outer wall of the artery where hemodynamic stresses is greatest. And that's why the aneurysm point in the direction that blood would have gone if the curve at the aneurysm site was not present. Now, this actually tells us that the stress is maximum at the outer wall of the artery at the curves, and henceforth the clip needs to be applied parallel to the apparent artery with aneurysms at the curves, which holds true when the aneurysm arises from the ophthalmic artery or superior hypophyseal artery. So there is a difference in how you apply a clip in these 2 scenarios. Now, one is perpendicular to the afferent artery, one is parallel to the parent artery. But then this actually helps us to understand how the clip needs to be applied. And the 4th is when each aneurysm is associated with a set of perforating arteries, and that's when we need to be preserving those peripheral arteries by trying to apply clips parallel to the line of perforators, which is very true when we are talking of an anterior communicating artery aneurysm or a basilar bifurcation aneurysms. Besides this, what we need to understand that not every aneurysms, they conform to the Rotten's rules, and henceforth there may be certain differences, but then these differences are not very clearly evident, and henceforth we like to stick to this Rotten's rule in most of the cases. Now, coming back to the preparatory steps, the first is to strategy to control the brain swelling. Now, this can be done with an external ventricular drain or lumbar drain. In our setup, what we do is we like to restrict these procedures only after the patient has been intubated, so that all other painful procedures are not performed when the patient is awake and alert, because this actually puts the patient at risk of a rupture of aneurysm before we even plan the surgery. We try to release the CSF as soon as possible. So that's why on the left-hand bottom, you can see we are opening up the cistern. And this cisternal drain opening has to be by a sharp scissor and way to the deep so that we can open up the interoptic and keratooptical cistern and drain the CSF. This relaxes the brain a lot, and then we can slowly get more spaces to work within. And also, if in case there is an intracranial hematoma, draining the hematoma also creates space. But then this is a strategy which we use only in those cases where we do, even after the releasing of the CSF, the brain is not lax, or the hematoma is very superficial. The reason why we do not want to attempt this particular strategy at the outset is that hematoma acts like a tamponade over the ruptured fundus of the aneurysm. And by draining the hematoma, we can actually release that tamponade. However, if we want to do that, we can actually remove some amount of the hematoma, trying not to evacuate all the hematoma at once. Keep a cotton patty over the deep-seated hematoma or over the hematoma, which you think is just abutting the aneurysm, and try to attack that only after the aneurysm has been clipped. So that's how we can actually allow hematoma evacuation without creating a risk to rupture of the aneurysm during the surgery itself. And of course, releasing arachnoid bands between the lobes and around the aneurysm is very, very demanded, because this actually allows, or rather prevents, any traction over the aneurysm fundus, which is particularly seen in the patients with PCOM aneurysms or with the MC aneurysms. So we need to remove all the arachnoids around the aneurysm and between lobes, so that the lobes of the brains are completely separated and there is no traction over the aneurysm as such. And also, we have to expose the efferent branches, perforators, and neck of the aneurysm all around before we try to cut the aneurysm or do some proximal or distal procedures. And beside this, we need to have a complete visualization from start to finish. So what we like to do is shift the microscope. So microscope always work in a keyhole principle. So the key, the smallest portion of the key is basically the craniotomy or the depth on which you're working. And then by moving the microscope on either side, we can actually see across the aneurysm. Now, idea is to maintain at least 15 to 30-degree difference between the angle where you apply, where you push in your appliers, and the way you're looking into the operative side over the blades, so that the operator's appliers do not come in front of the visualization. So this is very, very important before we try to clip the aneurysm. So once you have exposed the aneurysm, try to play with the microscope, try to play around so that you have enough of this space all around without obstructing your viewpoint. This is very important, and I actually ask my residents to achieve that before you try to hit on the aneurysms, because once the aneurysm rupture, you are in a fix. You cannot move around and you cannot play with it. So this has to be achieved beforehand before you actually try to hit on the aneurysm. Now, the most important concept of trying to avoid any aneurysm rupture or unexpected events is to soften the aneurysm. Now, aneurysm can be softened by either external clamping, that is to say, by applying some temporary clips or temporary trapping, and this can be usually done in the distal aneurysm by clamping the parent vessel by temporary, or in the patients with a proximal aneurysm by clamping the neck vessels or neck ICA. So this can be done, and then we can even use a suction decompression to collapse a giant aneurysm so that the pressure in it is far lesser. The other technique is by internal technique, which we can be achieving by inducing a cardiac by use of adenosine or deep hypothermic circulatory arrest with cardiopulmonary bypass. Now, these days, adenosine is very much commonly used, particularly to achieve a transient cardiac arrest for a few moments, during which you can achieve a clipping of the aneurysm, and that can even be around it. The other technique is a rapid ventricular pacing by inducing hypertension. Now, this also achieves a certain amount of softening of aneurysm. So these are the different ways by which you can achieve aneurysm softening. So what to use has to be planned beforehand. Because the anesthesiologist who is supporting you in your case has to be conversant with all these techniques as to what these surgeons are planning to do. And whenever we are doing these procedures, we like to declare it in our OR so that every team member knows what we are trying to do, because it's a teamwork. The surgeon cannot play alone. So we will have to have the whole team at the backdrop ready for all these procedures when it is required. And the beauty of these procedures are that you can actually repeat it often after a certain time gap, and this can be of very much help in difficult situations. Now come to the execution. Now, whenever we are applying the clip, we always like to keep it as simple as possible. So the first strategy is to use a single simple clip. Now, that needs an appropriate clip according to the size, contour, and configuration. However, even if it's fail, you do not remove that clip. You just leave it like as in this video as a tentative or a pilot clip, which actually holds the ruptured part of the dome. And then as you are going towards the neck of the aneurysm, you can use this tentative clip or the pilot clip to retract the dome away from the neck, and henceforth you can place the clip very low. Of course, you need to use the smallest clip possible in your armamentarium so that the clip does not cause any twisting of the parent vessel. as well as bigger this clip you leave inside the brain, it causes more problem by twisting the brain vessel. So we need to use the smallest clip possible. However, the tip of the blade should be away from, should be actually coming out of the aneurysm clip. So the whole of the neck should be inside the clip. So that should be the baseline. I'm repeatedly asked whether the repeated opening or sterilization of the clip does decreases the closing forces of the aneurysm clip. Now, this was a paper by Suzuki et al. In neurosurgery in 1987, where they have done a comparative study of intracranial aneurysm clips on the closing and the opening forces and the physical endurances. And in their study, they found that there's only 3 to 7% loss of closing pressure after 500 openings, the different cycles, and they didn't find any change even after continuous opening of the clip for 17 hours or for over 100 sterilization procedures. And these tests has been done over Yasardil and Sujita clips. So repeated opening and sterilization does not have too much of effect. However, there are some papers who have found that there had been a slight decrease in the closing pressure, in particularly clips made of titanium alloys rather than pure titaniums. Or even for that matter, cobalt alloy. So the recommendation is that we should not be using clips if in case they have been opened for more than 100 times. So that needs to be checked. And whenever you are storing your clips inside your boxes, then make it sure that those clips which have been opened very much frequently needs to be kept aside just to be on a safer side. Then we come to the and what type of clips we need to use, the standard or fenestrated clips. So if you see this figure on the left side, we can see a straight clip. And then what it actually shows is that the closing pressure over the clip is very much less as compared to over the base of the shaft. And that's why if in case we are applying a straight clip over a long length, over a long neck, then always remember that the closing pressure at the tip are lesser than the base. And in such cases, the fenestrated clips are very helpful because the alignment are completely parallel. The jaws are completely parallel, and the closing pressure can also be found to be equal between the tip and the base of the shaft. And henceforth, whenever we are applying clip over a long neck, it is always better to use a fenestrated clip. The other use of a fenestrated clip is again the fenestration itself, which allows the efferent vessel to pass through. So this is an ACOM aneurysm. You can see fundus of the aneurysm here in the neck. So we are applying a fenestrated angle clip. Now the fenestration has allowed the patency of the ACOM anterior communicating artery. However, it has occluded all the flow inside the aneurysm. So this ICG shows that particular flow. Similarly, the art of landing the aneurysm clip over the aneurysm is just like landing a plane. So it has 3 different movements, and all these movements are supposed to occur at your wrist. Your fingers and thumbs are only to apply pressure over the applier so as to open or close it. So all the movement has to be at the wrist. So there are 3 movements which we all like to perform. One is the rolling movement, which is along the length of the clip. Then there is a pitch, which is actually along the line of the applier. So the applier has to move up and down. So just to move a pitch. And then there is a yaw movement, which is along the long length of the vertical axis of the clip. So these 3 movements have to be practiced. So I teach my residents to do this outside the operative area so as to have a feel as to how the clip moves. So when you're doing it, try to look it underneath the microscope with all these 3 movements, and you can visibly see the tip. So try to look at the tip of the aneurysm clip when you are moving these 3 maneuvers under the microscope, and you will straight away feel that particular movement or the control of your wrist trying to move different angulation. Now, we also need to be aware of the pattern of aneurysm recurrences after applying clip. Now, this study, which was published in 2013, studied in detail as to how this aneurysm recurrences occur despite of applying a good clip. Now, the most common recurrence which has been found in 43.1%, 46% patients have been a distal aneurysm, which has occurred at the base of the shaft. Of this huge And then the other category had been in 34% patients where the recurrences had been on the lateral part, and then in 19% it has been in the proximal cases. Now, these three occurrences of the aneurysms most often is because of the faulty application of the clip. However, over the time, there are other two recurrences which has also been noted in different literature. One is a de novo formation of an aneurysm because of the weakening of the wall of the pathological vessel wall itself, or it can be because of the slippage of the clip itself. So these also have been documented in the literature. Now we come to the multiple clippings. So whenever we have a complex aneurysm with a wide neck or calcified and atheromatous sac, or whenever we have a lot of efferent or branches coming out through the neck or through the sac, then we need to reconstruct the neck of the aneurysm by using multiple clips. And idea is again the same, to preserve the caliber of the efferent and the artery, parent artery, to completely occlude the neck. Now, there are three basic steps when we are actually applying the multiple clips. One is that we have to close the aneurysm neck in a sequential steps, one after the another. We should always start from the deeper part of the neck, and then we move very superficially. And we also like to tackle the most difficult, the most inaccessible part be first. So this has to be done in these sequences so as to avoid any confusion or any problem later. Now, there are basically three different strategies by which you can apply multiple clippings, either by using intersecting clip, which are nothing but clips which are applied at different angles. The stack clips are tandem clips. So they are placed one over the another, and then they are overlapping clips. So these are the different ways by which you can apply. Now, intersecting clip, as I've already told, the second clip is angled into an initial clip. So this can be either of a simple variety or a complex variety. Now, as in this case, we have an ACOM aneurysm. Now, this ACOM aneurysm was filling from the left side. So we can see this is the aneurysm, which is actually protruding ventrally as well as anteriorly. So the ventral part was clipped using one clip, and then the superior part was clipped from the back of the ACOM using an intersecting clip formation. And then an ICG was done so as to see there's a complete flow in the ipsilateral A1, ipsilateral A2, then these are the opposite side. So, and there's no flow in the aneurysm. So this is the post-op images where you can see this particular thing. Now, multiple clipping techniques using stacking techniques. So there are basically two, understacking or overstacking. So understacking means that after the initial clip has been applied, there has been a small residual neck at the bottom, closer to the efferent in most of the cases, where you can apply another clip under the first clip so as to completely close the aneurysm. Now, another technique is an overstacking clip, where the first clip has been applied, but then again at the base there's a lift. So you apply a second clip over the first clip. So, and this is known as overstacking those clips. Now, this is an example of an ACOM aneurysm. You can see there is an erythematous sac, and which was not allowing the complete closure with the single clip. So we have to apply two clips. So this was an example of an overstacking clips. Similarly, in the example of an ACOM aneurysm, one can see this is the aneurysm coming out from the ACOM, basically from left side A1 ACOM junction. So we have applied a fenestrated clip, and then we can see the patency of the perforators as a patency of the efferent and the efferent arteries and complete occlusion of the vessel. This is another example of an MC aneurysm. You can see multiple lobe aneurysm coming from the bifurcation on the MC, and you can see an efferent branch coming out very close to the neck. So what we did was we applied a fenestrated angle clip over the neck first, trying to preserving the flow in the efferent branches. Now, once this aneurysm clip was applied, the first one, we used a second clip over the first one, trying to preserve the flow in the efferent. So this is the example, another example of an overstack clip using an fenestrated angled clips. Now, similarly, in a paraclinoidal IC aneurysm, so this is the drilling of the clinoid we are doing and exposing the paraclinoid segment of the ICA. Now we're using multiple angled fenestrated angle aneurysm. This is the tandem clipping, which has been done to create a fenestrated tube of the parent vessel, and then the aneurysm was completely occluded. Similarly, there are overlapping techniques where the second clip is applied over this first straight clip, which actually encircles the initial clip blade, bringing the heel of the fenestrated clip blade against the straight clip blade. So this is again a sort of an angle clip which is applied. Now, sometimes the neck is not clippable. In these cases, we have to apply aneurysm clip over the sac of the aneurysm. And this is particularly useful in those cases where the efferents are coming very close to the sac, or it is actually a part of the neck from which all these efferents are arising. So in that scenarios, we have to create fenestrated tubes. So these are various types of fenestrated tubes: integrate, retrograde, and dome fenestrated tubes. Now, dome fenestrated tubes technique is also known as pick and fence clipping technique, which is usually done whenever you do not have a good neck, and that's why we need to apply clips over the aneurysm sac. Now, the point to remember is that if the aneurysm sac is big, then you do not apply a straight clips. We rather use a fenestrated clips, because the fenestration will allow the aneurysm sac to stay inside and do not crush it, unlike the straight clips. So straight clips are only preferred for picket fence technique if the aneurysm sac is small. Like in this case of an acorn aneurysm, we have to apply picket fence of aneurysm clipping, because the aneurysm sac was small. And one can see there's a multiple straight clips which has been applied over the aneurysm sac. And subsequently, the aneurysm sac was completely occluded. However, the flow in the parent vessels were all maintained. So there are a few recommendations based on the location. However, it's not of a definite guideline. This is just a recommendation as to what a clip you can actually plan for as per the location of the aneurysm. So middle cerebral artery would demand an intersecting clip or even a tandem clip. PCOM aneurysm, a straight clip is good. ACOM aneurysm, a straight clip is stacked or fenestrated. Ophthalmic segment aneurysm, side angle clips, pericallosal, straight clips again. Basilar artery, tandem clips are much better. And for pica, it is the fenestrated clips. Now, coming to the evaluation part, this is a very vital part, because the first attempt of clipping aneurysm is always the best attempt. So we need to do a microscopic evaluation. Nowadays, we have endoscope, which can actually go around across the aneurysm into the small areas, and can actually let us know whether the complete clipping has been achieved or not. And similarly, one can puncture the aneurysm so as to see there is no flow inside there is no bleeding from the aneurysm sac once it is punctured. This actually tells us that the aneurysm has been clipped properly. Then intraoperative angiography or endosine green angiography comes very helpful. But however, there are various caveats one has to be aware of, particularly in the ecchymomatous or the calcified aneurysm sac, which may actually hinder the ICG flow, and it can actually create a false sense of a complete clipping. And similarly, Doppler flow probe can be very much useful to see whether the flow in the efferents and the parent vessels are well preserved. And if in case clipping is not appropriate, do not hesitate to go for bypass and trapping. This is very, very important, because I have seen many people who have applied a clip and think that they have clipped it properly, and without actually assuring a good flow in the efferents and the branches, and which actually invites problem in the post-operative phases. Now, we had done a small study almost 3 years back from now, which had included around 356 patients with aneurysm SH, and had 10% of multiple aneurysm. In that series, we have 70% patients who were operated as an emergency cases. So we always see for the Hunt and Hess grading, and we found that it actually correlates well with the MRS outcome. The most important finding of that study was that of all the cases, this clip reconstruction could be predicted preoperatively based on angiography, particularly looking at those aneurysms which had wide neck, where the neck has some branches coming out of it, and where the multilobulated architecture is there, or if you can see a calcified atheroma in the neck. So if you see any of these findings in your preoperative angiography, always be prepared with a with the armamentarium of clips do not only work with few clips. In these scenarios, we'd like to have a clip reconstruction, and henceforth that is very important. And the preparatory steps were done in most of the cases. In only few cases, that is only 3 of all the series, we had to do a suction decompression, and we had to use a fenestrated or non-fenestrated and tandem and random model. So we had an intraoperative rupture in that series of 5% and delayed ischemic neurological deficits of 3.3%, and we did not have any recurrences in this group, which were followed over 3 years. Now, of course, this all art which I'm talking about has its own share of complication, which has been reported in various literature as well as in my series too. So residual neck has been seen in 28% of cases, and this is particularly seen in different technique, because we remember this particular technique is applying the clip over the aneurysm sac rather than aneurysm neck. And then there is no branch arterial occlusion, which has been reported with a well-conducted reconstruction. Mortality has been 4%, which is usual, standard for now. And of course, unchanged neurological outcome had been there in 60% patients with only 36% improvement. So atherosclerotic changes at the neck is a major challenge. So one needs to be aware of that it can slip your clip and can compromise the lumen. So in these cases, one can apply a booster clip over your first clip you should apply. Now there are unusual situations which are in these days, particularly with the rise of the coiling techniques. Even though the coiling has been reported to have very good outcome in initial phases, we all know that the chances of recurrence is far, far higher in coiling as compared to the clipping. Now, the refilling has been seen. Neck replacement has been seen in 26% cases of coiling as compared to 12% of clipping. However, the annual retreatment rate is very high, as approximately 13.3% with almost 2.6% clipping. So whenever we like to counsel the patient, we actually say that the clip coiling has 20% chances of residual aneurysm or recurrences, of which 10% would require intervention on a later date. Now, this recurrences has been classified by various authors. Bremen-Roy classification is the most common which is being used. So class 1 is normal, where there's a complete obliteration. Class 2 is where there's a residual neck, as can be seen here. This can be because of the compaction or the hammer effect of the blood flow inside, or the growth of the aneurysm. It can also occur. And then there's a class 3 where there's a residual aneurysm seen because again of the compaction effect. However, Lee Boy had actually had a very good classification based on angiographic study, and in which beside the complete obliteration, the grade 1 recurrences is basically of a recanalization, where there is a recanalization inside the aneurysm sac. However, there is no aneurysm growth, there is no aneurysm neck form. Then type 2 is where there is a compaction seen, and that's why some of the aneurysm sac is getting filled with the contrast, but then there is no growth of the aneurysm sac itself. In the category 3, it is the neck which is forming, but the aneurysm remains still the same and there is no compaction seen. In type 4, it is the neck as well as some amount of compaction seen, so you can actually see the contrast filling the aneurysm. And then type 5 is when there is a new neck as well as a new sac or de novo formation of the aneurysm. So these are the different types of recurrences which has been Now, why this is important for us to understand? Because clip reconstruction of these situations is very, very difficult, even though few of the authors have found excellent results. But then for people who are just starting with the clip reconstruction, particularly in the present scenario where the total experience of aneurysm clipping is decreasing because of the upcoming endovascular techniques, it is important for us to understand which type of clip reconstruction one can use and which types of recurrences. So if in case you see a compaction or a neck formation, which is more than 2 millimeters without any coils going inside the neck, these are the very good basis for clip reconstruction. However, if you have a no neck formation, where you can see some amount of coils going inside the neck or inside the perineum vessel, then these are very, very difficult cases for clipping and coiling. For clipping and removal of the coiling, people have reported removal of the coil, but these cases has very, very high incidences of stroke after the procedure. So in these cases, many authors have reported or rather suggested to do aneurysm trapping and bypassing rather than trying to remove the coil. And trying to do a clip reconstructions. Of course, when nothing works, then trapping and the bypass is the thing which we can all do. So this is a case of a bilateral supraclavicular aneurysm, which we had performed an ECIC bypass. So to conclude, clip construction is a challenging yet rewarding art. It needs a very careful planning and execution, which can actually achieve a very good results. And of course, the philosophy of keeping it simple is always comes very handy. So we have a lot of things, a lot of armamentarium these days, but then we should always try to do that thing which is very simple, less cumbersome, does not cause too much of problem to the patient. So we should always think about it before we apply. And as a surgeon, we all have been practicing it. We should actually plan before we operate. So we should actually have a mental rundown of the whole procedure, starting from how to achieve the brain relaxation to how to achieve a good control of the aneurysm, and then what to do in cases in the case there's an intraoperative rupture of the aneurysm. So all this thing has to be mentally planned and executed before an actual execution of the aneurysm clipping. So this is my team at Kathmandu Medical College. I'm blessed to have very good colleagues and of course a very inspiring residents with us. And of course it is the happy smiling faces of the patient which gives you a lot of reward after a very painful stress. So thank you again for a patient's listening, and I will be happy to answer inquiries.
Thank you, Professor Tahapa. And it's a great honor to see your excellent presentation. And so successfully treated cases, I was so surprised to see that. So I totally agree with the concept of clip application concept, basic and also the advanced technique. We need to take it into consideration to apply the aneurysm clip to appropriate angle and to the appropriate location of the neck to clip the blade completely. So in your presentation, you mentioned in clipping the aneurysm, we need to first to apply the deeper first. Under the near the next is the most important, one of the most important things to apply the clip. And of course, we need to preserve all perforated around the neck, around the parent artery. So to do that, we need to see the adjacent surrounding the anatomy before applying the permanent clip. So very important concept. And it's so interesting for me is in the concept of clipping and like a landing a plane. You mentioned in a presentation, and the load and the yaw and the pitch is like a landing plane. It's a very nice concept to apply the clip. We need to know about it. So I have several questions of you. So your presentation today is the timing for the clipping the aneurysm. So in your country, how you treat the patient with a ruptured aneurysm, and in the emergency case, on the day of rupture, on the onset, or the after the next day, or you operate the patient from the next morning, or something like that. How about you? Comment. Thank you.
Thank you, Dr. Kimura, for a very nice summary and for this question. Well, this is a very appropriate question because most of the residents will be listening to this talk. What we do in our practice is that we need to have a complete workup of the patient, particularly of the angiography and evaluation of the patient before we embark on any procedure. So that's until we have a complete workup of the patient, we do not jump immediately. Second thing we like to see is the overall condition of the patient. If the patient is hemodynamically stable, if the patient GCS is good, we do not like to wait. In those scenarios, we like to go immediately as soon as possible. However, the patient is having a poor break, Hunt and Hess, or a poor GCS, then it's in that scenarios, we like to do some salvage procedure, particularly during the CSF to drain the CSF. To decrease the ICP or to ventilate the patient till the patient conditions improves. However, our basic tenet is that in cases of ruptured aneurysm, we like to clip as soon as possible to avoid the risk of re-rupture because that is more fatal. So having said all this, we like to discuss all this pluses and minuses with the patient family. And this is very important in this scenario because particularly in the present days where the legal medical legal thing is very much rampant, we need to keep the families also in confidence as to what we are trying to do. And we like to give them all the offers. We have nowadays in Nepal, even endovascular guys are doing very good job. So we like to give them an offer for these treatment modalities too, telling them about the previous results which the literature shows, and then we come to a decision. So if I answered your query.
Pardon? Yeah. Yeah, we need to, in a university, we also perform the emergency surgery within 24 hours. On the day of the onset, we need to perform the clipping surgery or the coiling for the depending on the patient condition. Yeah, as you mentioned, yes, I totally agree with your comment, with your opinion. And my next question is, you mentioned in your presentation in the recurrence of the aneurysm after the coiled aneurysm, and so how you decide to the patient with a recurrent coiled aneurysm, how you can perform the clip aneurysm or the recoil aneurysm, or how you decide to the patient on the aneurysm imaging?
Thank you for that question. This question has been answered by a lot of literature which is coming these days. Thankfully, because of a lot of patients who are undergoing endovascular coiling, definitely with large number of patients who are getting coiled, we are also looking at large number of patients who are getting recurrences. And people have been operating on these aneurysms, and what they have found in the literature is that the chances of treatment failure, that is recurrences after an endovascular reattempt of closing those aneurysms, is far higher, to a tune of 50%. And so they like to see as to what are the markers of recurrences after coiling or recurrences after recoiling, I should say. So those markers which they have found, as if in case there's a compaction of the pre-coil aneurysm, if there is a wide neck, if there is an increase in the size of the sac. Now, these are the different markers which they have found actually predicts that the patient will fail even after a second attempt of endovascular coiling. So in these scenarios, it is advisable to go straight to clipping rather than subjecting the patients to a repeated attempt of coiling. Now, coming to the other part of the question, what type of surgical maneuver we like to do? It depends upon the presence of the neck and the compaction. If in case it is more than 2 millimeter, it allows our clip to stay in the neck, and henceforth we like to measure that particular neck, the neck length, which is possible, which allows us to place a clip there. And the second thing which we like to see is any presence of coil element inside the neck or inside the parent vessel. Because these structures, if in case they're inside the neck or in the parent vessels, they have a very, very high chance of rupturing the aneurysm neck while trying to clip the aneurysm or injuring the aneurysm parent artery. Now, there is a very good publication which has actually told about the attempt of removing the coil from these places while they were applying the clip. And they found that the chances of or the risk of stroke is very high in these cases where the coil had been retrieved while trying to do a clip reconstruction of aneurysm. And as for the recommendation these days are in these scenarios, it is better to trap the aneurysm and then do a bypass.
Actually, I totally agree with your opinion. So in that some difficult situation, we don't hesitate to make a bypass surgery before approaching to the aneurysm. In the trapping of the parent artery, of course, especially in the emergency case, we need to apply the clip, perform the bypass surgery before applying aneurysm itself. And
yes,
totally agree. There's some difficult situation, but we especially in the emergency case, we sometimes tend to hesitate to make the complicated surgery, but we should not hesitate. Of course, I totally agree with your comment. Thank you. And so in the my third question is in the ruptured case, your emergency case, before aneurysm exposure, when you encounter the premature rupture, occurs, how do you perform first? Of course, blood pressure should be lower than your your intention, of course. And the next procedure, how do you perform the to control the bleeding, intraoperative rupture? What's your comment?
So it all depends at what stage should be. Yeah. So it all depends upon at what stage of surgery we are in. If in case we are just like raising the dural flap, it has occurred in few of the patients where we are raising the dural flap and the aneurysm ruptures. Then we are actually in a tough situation because we are not exposed anything. We are not open up these cisterns, leave aside approaching the parent vessel. So these are the scenarios where if you have a possibility of a cardiac arrest, one can do that for a while, but then of course you need to work very fast in that situation because you don't have a lot of time to dissect as shown in my presentations. However, if in case if you are very near to the aneurysm and you think that the aneurysm fundus has given away and the fundus is very much approachable, it's very mandatory for us to put a cotton patty over the site where it is bleeding, presumptively bleeding, because then you are not having the bleeder on your actual site. So one can place a cotton patty over that presumptive site of bleed and then keep it pressed over with a suction, a wide bore suction. Now that allows a clean feed for us, and then we do not work on that site. We go either proximally to the parent artery as soon as possible, so as to apply a clip in the parent vessel, and then this actually allows us some time to work around the aneurysm and come back to its own place. So these are the different strategies one can do before even a dissection of the parent artery is done and the aneurysm ruptures.
Yeah, thank you. Yeah. Thank you, Professor Tahapa. Yeah, so amazing techniques you talked about so much. I learned a lot. I enjoyed a lot. Thank you. So how about Roger? You have some comments? Thank you.
Yes, sure. Thank you. Thank you very much, Professor Amit Thapa, for this wonderful lecture. I learned a lot and totally agree with your management decisions. One question that I would like to put across to you is, what is your plan in cases of blood blister aneurysms? What do you do in such cases? Because clipology hardly works there. So is it upfront bypass or you do something else?
Well, it all depends upon the blister aneurysm has appeared as a case of a ruptured aneurysm, or it is just incidental finding. Because if in case an incidental finding, then we usually just wrap it and leave it, because then it is not too much of a problem later on. And the muscle wrapping, which we do is not with a clip, we just do a muscle wrap or a muscle wrap over these incidental found at blister aneurysm. However, if in case that blister aneurysm is a ruptured aneurysm, then that is a serious issue. That means the whole wall is weakened. And in these cases, putting that clip is not an answer because clip will not have any base to hold on. So in that cases, the best options would be a bypass rather than trying to clip and then going into a problem. So if a blister aneurysm is a source bleeding, then of course a bypass would be the answer rather than applying any clip, or even for that matter, a sewn clip is not going to help. The whole vessel is diseased.
Thank you. So you too agree with Professor Baskaya's methodology of upfront bypass for blood blister ruptured aneurysms. I also fully agree with your first strategy of recurrent aneurysm that you mentioned, that you don't try to remove coils from the neck because it has higher rates of strokes. I also wrote about recurrent aneurysms when I was in Japan in the ACNS, and we had 4 cases where we had recurrence after coiling, and in all the cases we had done upfront bypass. So it is the best choice with not trying to attempt to remove the coils from the neck. So thank you very much. We can take comments from Professor Shubin as well, who is an expert here. Professor Shubin.
Yeah, thank you, Professor Amit. Thank you for your presentation. And for Kimura's question, I have a colleague from Tiantan Hospital. he preferred to use keyhole approach to treat even the emergency case.
Really?
Yeah. So actually, he said even in the keyhole, actually the somewhat the pressure of intracranial is higher than the normal craniotomy, but actually he said that this is protective for the premature rupture. Yeah, and even rupture, actually the high pressure can preserve the so if you only do the proximal and the distal clip, temporal clip of the aneurysm, you may have the time to treat the neck of the aneurysm. So it's normally it's another thinking. Yeah.
Well, maybe depending on the patient condition, if the patient keep the condition consciousness alert, and it may expect it low condition intracranial pressure. So in such a case, we can perform the not so large craniotomy. It's just only a small craniotomy may be allowed to perform the clipping surgery to approach the softened brain, and we can approach dissect the cerebral fissure easily, and we can approach to the aneurysm itself, of course. But often, you know, the swollen brain in the with the comatose patient, maybe the intracranial pressure elevated so high. And so in such a case, of course, we don't need to perform the keyhole surgery. Of course, we need to large craniotomy. And before making a craniotomy, you need to, the patient, the blood pressure should be lower than we, as possible, as low as possible. So
yeah, that's for sure. Yeah, it's only for the conscious patient.
Yeah, conscious patient maybe selected the case, but
yes,
we need to know about the advantage of the keyhole surgery. In the unruptured cases, on the benign tumor cases, the patient is like planned surgery, not the emergency case. The patient is still awake, and so alert patient, they will intend to perform the minimum surgery. But the emergency case and the ruptured cases, I think the patient needs a safe surgery, even than the minimum surgery. In such a case, we don't need to choose a keyhole surgery. But just finally, just a patient condition and the surgeon preference, maybe. But I don't.
Yeah, me too. I just transfer his opinion.
Thank you.
Yeah. And talking to the Bristol-like aneurysm, normally it's a frontal ICA wall. So normally it can be fixed directly. Use wrapping technique, and the wrapping if you use even you can use some cotton to wrap the ICA wall, and use additional clip to make the wall fully covered. Yeah, and actually most of the Bristol-like aneurysm I treated this way, but not bypass. It's too tedious and unnecessary. Mostly it can be treated directly.
Understood.
Yeah.
We can take one question from my co-host Libun Singh.
Thanks, Raja. Thanks, Professor, for a very nice presentation. Just want to ask Professor, do you think that the clipology are far behind the endovascular because there's no innovation, invention for the clip design and even the technique for many years? And then another I want to ask for you that another myth in clipping is the vasospasm period. We should not to clip within 4 to 7 days because of vasospasm. That is a myth. What's your opinion? Thank you, Professor.
Thank you, Dr. Liu, for a very nice question. In fact, the second thing I didn't thought over. So regarding the first question, regarding whether we are way behind the endovascular, well, the invention is basically brought up by the necessity, and these days people are going into minimal invasive. So rather than the clipology, people have actually moved into keyhole or endoscopic clipping techniques rather than clips itself. And with this, we have also seen a certain changes in the clips formation and the application. Nowadays, rather than applying a clip which has a holder or a plier coming from outside, we have clips which are coming from inside, so that we can actually apply a clip from a small corridors or small spaces. So of course, there has been some changes in the clipology, as well as with the advent of CT and MRI. Rather than using an alloy, titanium alloy, people are now going into a true titanium or titanium clips, which has been shown to be having a much more better or rather a preserved clipping force despite of multiple sessions of sterilizations and opening and closing things. So clipology has also changed over the years. But then you are right, as the advancement it was there in 1940s and 50s, the number of the clips which the previous predecessors of neurosurgery had been using, those clips and those formations have not been improving too much. But of course, the type of material and the application thing has changed over this period. Now, your second question was regarding. Can you please repeat the second question? I just forgetting it.
Vasospasm, day 4 to day
Yes.
7, not suitable for clipping, is a myth. What's your opinion?
Well, this is a myth, I should say, because in my scenario also, patients who come on the day 4th and 5th, if in case we do not see any angiographic or clinical manifestations of vasospasm, we go in and operate, and we do not see those patients having vasospasm even after the surgery. Of course, we like to confirm it beforehand by at least 3 techniques. So we do a transcranial Doppler, we do a clinical examination, of course, and then we also should see for the angiographic evidences of vasospasm. And if in case there are none in these patients, so rather than only relying on the duration of the aneurysm of the SAH, we like to go ahead. Now, the problem in our scenario, particularly in Nepal and the developing countries, is people actually do not come to the doctor immediately. So they may have bled a little earlier, but then they like to stay at home, thinking that just such a minor headache and it would go by its own. So these things also actually do not tell us as to the actual time of bleeding. Rather than just staying for 4 or 5, staying on the time of the bleeding, 4 to 7, historically, we like to see the evidences of vasospasm.
Thank you, Prof.
Well, thank you very much. Now I think we can conclude and hear the concluding remarks from Professor Kimura.
Thank you, Professor Amito Tahaparo. We learned a lot for your clipping techniques. Clipping technique is very important to apply the clip, how to manage, how to clip, how to apply landing the clip to the aneurysm neck is very important, even in the vascular era. So yeah, thank you for your presentation.
Thank you very much. We indeed had a very wonderful session with both of you, Professor Thapa and Professor Kimura. Now we can go to the second session, and I would like to invite Professor Shubin to say the introduction part, and then we will in turn invite Professor Lee and Professor Shubin.
Okay, now let's invite Professor Duan Lian from a military hospital, and he treated Moyamoya disease for more than 20 years, and he also have a lot of experience in the indirect bypass, so-called bypass surgery for Moyamoya treatment. So let's, Professor Duan Lian, the time is yours.
Thank you very much for inviting me to be here, Dr. Professor Xubin. Today the topic is indirect revascularization for the Moyamoya disease. As we all know, Moyamoya disease is a special type of cerebral vascular disease which characterized by internal acidosis and occlusion at the internal carotid artery, and perforate arteries at the base of the spleen compensatory expansion when performed angiography, or it looked like it's a proof of smoke, and so it called Moyamoya disease. Although 60 years has passed since Moyamoya disease was regarded as a new disease, its etiology and pathogenesis is still unknown. So there is no definite and effective medical treatment so far. This picture is from Dr. Matsushima, who is my teacher. From this picture, we can see vascularizations of Moyamoya disease only limited here. That means half part of Willis circle. The other part of blood vessels are normal. So it gives opportunity to our surgeons to transfer the blood flow from extra cranial circulation to the intracranial circulation. There are dozens of methods of cerebral revascularization surgery. The first direct revascularization procedure typically is STMC bypass, and indirect revascularization procedure such as bowel surgery, encephalodural arterial myosin analysis, EMAs, and EDAS, and combined surgery. Combined surgery means combined direct and indirect bypass, and combined plus surgery. Combined plus with the plus surgery means with some tissues with rich blood supply. So today I will show you the bowel surgery at first. This is a 10-year-old girl with ventricular hemorrhage. This is a typical Moyamoya disease, stenosis and the Moyamoya vessel formation. After ventricular drainage for hematoma, several months later perform angiography for this young girl. We can see good collateral circulation will develop from STA, external carotid artery, and to the surface of the brain. That means bowel surgery. The other case is a 21 years lady, also with ventricular hemorrhage, is typical Moyamoya angiogram. So both sides performed bowel surgery for hematoma drainage. After several months, we perform angiography. We also can see a good collateral circulation well established from ECA to the ICA area. That means both two hole surgery, but even both holes, one hole or two hole surgery, the amount of blood flow is not so sufficient. So how about both multiple holes? This is a chemical case with she is a 49 years old lady with left limb weakness, a typical Moyamoya angiogram. We can see multiple bowel surgery was given here. After 14 months later, we performed angiography for her. We can see a lot of blood flow from IC to the surface of the brain, but the symptom of this of her symptoms, left side weakness disappear, but still left some slightly deadness. That means that this is the right side angiograph. This is the left side angiograph. That means even both multiple holes, the blood flow is not so sufficient. So how about the EMS? That means we use temporal muscle as a blood supply. This is a 23 years old lady, the typical Moyamoya disease. So EMS was given to her. After several months later, we did angiography. We can see a lot of blood flow from IC to the surface of brain to the IC. That means EMS is also effective. I show this is a chemical case. I show another case is a hemorrhagic case. This is a typical Moyamoya disease, right side and the left side. This is a hematoma, after hematoma removed. Several months later, we perform angiography. We can also see the blood flow from articular arteries into the surface of the brain. So that means EMS also effective for the Moyamoya patient, even in hemorrhagic case. So evolution of treatment of both surgery and then EMSs. I think these two methods is effective, but blood flow is not sufficient and result some defect of the skull. Today, I will talk about EDAS, who was established by Dr. Matsushima in 1979. EDAS is usually for the children and more effective. I show you EDAS for a child patient. This is 10 years old with left limbs lumbaless and weakness for 2 months. After surgery, we can see ICA narrowing become gradually become severe, but we can see ECA angiography. This is STA almost replace the MCA area. This is it for children. How about it for the adult patients? This is a 39 years lady with deadness. For 1 year, this is the angiogram, ICA stenosis, and some Moyamoya vessels formed. After EDAS, several months, we can see ICA, especially the left side, gradually became serious, but we can see Okay, this is an adult patient. It's a typical Moyamoya disease. This pre-operation, operation, and post-operation ICA angiogram. This is ECA angiogram. That means STA almost replaced MCA area. That means EDAS is effective for the adult patients. I will show you another 16 years old patients with noise and vomit for more than 20 years. This is a typical Moyamoya angiogram. We can see here in ICA almost stenosis, real stenosis. We give him EDAS several months. We can see ICA was closed, and the ECA angiogram, we can see STA almost replaced MCA. So that means EDAS is effective for the old patients. That's another one, another case. As I show you, this is a 60 years old patient. Mid MCA was almost closed. This is ECA. We performed EDAS for him. We can see this is this is ICA postoperative. This is ICA. ECA. This means STA angiogram. We can see blood flow from ECA into the surface to the midverse MCA. That good collateral circulation were developed even in 7 years old patients. Are there any, maybe you can ask me, are there any no effective patients? The answer is certainly. I showed this patient. This is 30 3 years old patient with Moyamoya disease, a typical Moyamoya disease IC angiogram. We can see stenosis. We give him either this is ECA angiogram. We give him EDAS for 2 years later. We re-examine angiography. ICA also the same compared the 2 years before. No any character circulation developed, but the symptom is free. After 5 years, another 5 years later, ICA stenosis become worse and serious, and STA in place the MCA. That means the blood supply demand depend on the demand of the ICA. They will keep the balance between the demand and the supply. This is his posterior angiograph. This is preoperative and 2 years. At that time, no collateral circulation developed. Another 5 years later, posterior artery also closed, almost closed, and the infarction at the occipital lobes. So I show you this balance case. At first, this is a children case. This is pre-operation. We can see both sides IC stenosis and the Moyamoya vessels formate. Pre-operation, and this is ICA and this is ECA. 2 years later, the ICA nerves gradually become service, and collateral circulation started as established. Another 3 years later, blood flow from ICA gradually decrease, and from ECA gradually increased. They will keep the balance between the demand and the supply. This is for a children case. I show another adult case. This is a 20 years old patient with limbs weakness. 2008 and 2013 and 2008, ICA nerves gradually serious, right side and left side, and the blood flow from STA gradually increased, the right side and left side, pre-operation and post-operation. Even in the adult patient, they also can keep the balance between demand and the supply. This case, I want to show you, in 31 patients, not only involved in ICA, but also posterior artery also involved. We can see this ICA gradually become worse, right side and left side. But the posterior artery also become worse gradually. So in that kind of case, we only perform the EDAS for both STA is not enough. We should give him occipital artery EDAS or bypass. In this slide, I want to show you how long time does it take for collateral circulation, collector circulation developed by EDAS. This is an adult case with infection right side. This is pre-operation STA, ICA. we performed we give him ADAS in 2004, September 2004, and performed angiography for him in 2011. We found good circulations was established only in 40 days. That means EDAS in adult patient with infection, 40 days as collateral circulation was established in 14 days. How about in children? This is a 5 years old young girl. This is a typical Moyamoya disease, operation with operative angiogram and post-operative angiogram. We give him EDAS. This is a IC angiogram, the right side, left side. After 6 years later, we perform angiography for hair. We can see good collateral circulation well established, but the posterior artery also stenosis. So we want to perform the occipital artery for hair. This is a post-operation 1 day. When normal CT scan cannot find anything. This is normal. This is an operation area. But 1 week later, suddenly hemorrhage of this case. We want to know the bleeding reason. We perform angiography for this patient. We can find here the occipital also occipital artery already supplying blood to the posterior area. This is left side occipital artery. That means EDAS only need 1 week will develop the good collateral circulation in children. How about the EDAS for infarct patients? This is a 10 years old young girl. We perform both sides EDAS for her. At that time, I don't know. EDAS is work for this kind of patient. I don't know. I just try. That means 2005 years. And then 2019 years, this young girl become a young lady and work as a clerk in staff in his father's school. We can see this is a IC angiogram and the pre-operation and post-operation. Also, almost IC was closed. This is ECA. We can see the right side, no infection side is good collateral circulation was established. But even in left side, in this case, infection side, also some collection circulation developed. That means even in infection case, the EDAS is still works give some blood to the brain. Is there some helpful for this kind of patient, especially in children? This slide I want to show the patient family. They're always asking me how about donor blood vessels? Donor vessels will become stenosis or occlusion. So I show you this patient. I performed the EDAS in 2006. And in 2019, we can see ICA was almost closed to pre-operation, post-operation. Our ICA was almost closed, but ECA almost normal, no any stenosis or narrowing is still supplying. The patient with also symptom free. So I think this is special things. And this case I want to show you is a direct and in the indirect bypass for the same patient. This is 50 years old patient with intermittent left limb weakness. This is his angiogram, right side and left side, stenosis and Moyamoya vessels, preoperative angiogram. We performed the EDAS in 2008. This is a pre-operation, and half years later, and 9 years later, and 13 years later, we can see IC gradually because stenosis become serious gradually. The IC also already occluded in the last year. We can see the ECA. This is a pre-operation and the post-operation. This is the EDAS. This is STA-MC bypass pre-operation, and STA bypass 1 year later, EDAS half years later, and 9 years later, and 13 years later. This is one patient, two sides. One is a direct, the other side is indirect. So I think from this patient, we can see both methods are effective. The results are almost the same. So we can understand from this above the patients, the EDAS and both surgery and EMS are effective, can acquire sufficient compensatory blood flow, is effective for the ischemical case with Moyamoya disease. How about it does for the hemorrhagic case? I show you this is a hemorrhagic case. This is a 39 years old lady with a ventricular hemorrhage. Angiograms, this is a typical hemorrhagic type of Moyamoya. We performed EDAS in 2007. 2 years later, we can see good collateral circulation well developed. At that time, I think it's maybe it's very helpful for her. But another 5 years later, hemorrhage again here. So I think at that time, I think maybe it's necessary for us to perform another surgery, bypass surgery here. So I just accepted artery surgery for her. One day after operation, hemorrhagic bleeding here. So from this case, I can understand that surgical revascularization does not mean that rebleeding can be completely prevented. Conclusions. I think indirect cerebral revascularization can increase the intracranial blood supply and may reduce the incidence of stroke. Personalized surgery may be appreciated for operation option. The mechanism of indirect cerebral vascularization deserved further study. Thank you.
Thank you, Professor Duan. So, Raja, do we have some questions or comments?
Well, you are the man of Moyamoya. Maybe you should give your comments first.
No, actually, this indirect revascularization is a very important treatment for Moyamoya. So actually, Moyamoya disease has a lot of treatments you can select. Yeah, and EDAS is one of them. For the most of the patients, especially the children younger than 12 years old, normally I only use indirect revascularization. But my way is EDMS. So normally the EDMS is wider. The incision is wider, and it can cover much wider cortex, and the revascularization not only including the STA, but also the MMA and the deep temporal artery. So I already presented in my presentations. But Professor Duan's method is also very important and also achieved quite effective in some of the patients, and it's a kind of method to treat the Moyamoya.
Thank you very much. We can take comments from Professor Kimura. Professor Kimura.
Thank you, Raja. Thank you, Shubin. And thank you, Professor. And yeah, I understand your concept. Of course, some Moyamoya patients, especially in the children cases, can receive the sufficient volume of the blood supply by just performing the indirect bypass, just like EDAMS and EDMS or something like that. Yeah, I can agree with your comment, but in your presentation, you showed that even in the adult cases, the patient can receive the emergent sufficient adequate volume of blood supply after EDAMS, indirect anastomosis. I was a little bit surprised to see that even in the adult cases. Yes, of course, I know even in the adult cases, in the indirect bypass may be effective in some cases, in some patients. But my opinion is the Moyamoya patient can only single chance to improve the blood supply after only one chance perform the surgery. So in my university, I treat the patient to combine the surgery. I recommend to perform the surgery. Direct, of course, direct and indirect bypass. At the same time, we should perform. Only one chance patient can be given, only one chance. So my question is, how can you treat the patient after the indirect anastomosis only? So if the patient suffer the ischemic, transient ischemic attack, so how you perform the additional surgery to the patient? Thank you, Professor.
Really good question, Dr. Kimura. I understand what you want to say. Actually, it's very interesting question. Mm-hmm. If EDAS not effective, that means no ischemic symptoms, or almost no ischemic symptoms. Mm-hmm. If they need the blood supply, they will develop the circulation. Mm-hmm. So at the beginning, I don't believe this kind of operation is a effect. Mm-hmm. At that time, I learned this method from Dr. Matsushima in Tokyo Medical and Dental University. I do not believe anymore. Even in children, I cannot believe.
Yeah, really.
But when come back to China, I do this surgery for the children, but effective. But how about this method for adult patient? Mm-hmm. I just try. Mm-hmm. I'm also surprised. Mm-hmm. So the importance is for us is to research the mechanism of the indirect bypass. Why the blood flow can into the surface of the brain? The reason we should understand. Logically, I agree with your opinion. Combined surgery maybe the best one. Mm-hmm. But actually, I show you a lot of case that mm-hmm. the patient tell us that EDAS is work well.
So actually, in fact, how many patients can receive the sufficient volume of the blood supply even in the indirect bypass only? So not only patient can receive the indirect bypass only. Is sufficient volume of the blood supply by making the indirect bypass cases. In some patients should be performed the direct in some patients should be received direct STMS and MC anastomosis combined surgery. We should select a patient. In some patients, we can just perform the indirect bypass only, but in some patients, we should perform the combined, of course, including the STMC bypass surgery. In some patients, should be performed the double barrel anastomosis. We should choose the patient. It's my comment. Thank you.
You are ready. You are right. I agree
Yeah.
with you. I mean,
Yeah.
you mean to select the patients.
Yeah.
How to select the patients for direct and indirect patients. So I think that there are something in here. So
But yeah.
yeah, this something I want to know. Yeah.
Yeah, but severely disturbed the blood supply, so decreased blood circulation. Yeah, in some case, in such a patient can undergo the combined surgery. Just the extent of the ischemia, and maybe
Yes, right.
one point for the selection.
Yeah,
it's just my comment. Yeah.
Ischemic is chemical. That means decrease of the cerebral blood flow is key point.
Yeah.
That means demand.
Yeah.
Demand decide the supply.
Yeah. Yeah. Yeah, of course. Yeah, demand is of course we just need to supply.
It's hypoxia of the cerebral hypoxia.
Hypoxia.
Yeah. Yeah. So actually, this is also an important method to treat Moyamoya in selected cases. Yes. But normally always effective in adult patient, especially for the hemorrhagical Moyamoya, especially because, you know, about half of the patients in adult Moyamoya, they suffered from hemorrhage as a first symptom, but not very severe ischemic condition.
Yeah.
So actually, I agree with you that I always use combined treatment. But I think the spontaneous stoma come from middle meningeal artery. If the preoperative the angiogram already shows some spontaneous stoma already come from ECA branches. Actually, it's a good sign for the indirect revascularization. In this kind of patient, if you do the indirect revascularization, it
not
always have a better result. Yeah.
I see.
I agree with you.
Yeah, thank you for your comment. Yeah.
Thank you very much. Professor Amit Thapa is still here with us. Would you like to say something, Professor? Your mic is unmuted, Professor.
Yeah, Professor Duran, thank you for a very illustrated talk, and your collection of follow-up images is excellent. And I should appreciate that you have been following the patient for over 15 years, 20 years. So that's marvelous. Just a quick question from you. Over the period of your examples have shown that revascularization could be achieved as early as 10 days in few of your cases. Now, my question to you is like, how and when do you decide that in follow-up scans, a patient may require some supplementary procedures? Have you ever thought of that?
Yeah, good question. Actually, most of you are performing the combined surgery for the adult patient, right? Only me performed indirect surgery for the adult patients. So I should follow up. I should understand that this method is effective or not. Generally speaking, I will follow up at 6 months after operation, and 1 year, 3 year, and 5 years, and 10 years. Because for hemorrhagic case, the yearly rebleeding time is during the 2 to 8 years post-operation. So that period is very important for us. Just as Dr. Xu Bin said, the EDAS is not so effective for prevent the rebleeding. I also have no confidence for the hemorrhagic case, but ischemic case, I think if we select the suitable, we will get the good results. That means good collateral circulation will be developed.
Yeah, actually, Professor Duan, he did a lot of investigations in the Moyamoya genes, and also the epidemic of the disease in the different Chinese district. And he also have a lot of this kind of investigation results. And maybe next time we will invite you to present this kind of experience. And this is also very important aspect of Moyamoya disease. Yeah.
Thank you very much. Of course it is. Any questions from my co-host, Liu Bun Seng, before we wind up?
Thanks, Raja. Thanks, Professor, for a very nice presentation. My question, Professor, those who already have pre-existing ECA, ICA network in reperfusion, would the surgery disrupt that network and cause more disaster? Thank you, Professor.
Sorry, I cannot.
Yeah, because just now Prof. Zubin have mentioned that some cases they already have stoma from ECA to ICA even before surgery. So would the surgery itself cause disruption of that and it cause condition to be worse than before surgery? Thank you, Professor.
You mean before we perform the surgery, we can find some artery from dural matter and into the surface of the brain already.
Yes.
So I think the mini artery, middle artery, the blood from middle artery from dural matter, it's not so sufficient. So just
Dr. Liu's, your question is about how to preserve the stoma.
Yes, how to preserve.
Middle meningeal.
Yes.
Okay. I can explain to you. Actually, the middle meningeal artery is normally frontier to the STS parietal branch, normally 2 centimeters frontal anterior, the location of the posterior STA parietal branch. So normally it can be safe, yeah. If you use EDAS, because only they need exposed, not very wide creotomy.
Yes, it's very narrow. Just 3 centimeters enough. 3 or 4 centimeters enough wide.
Thank you, Professor.
Thank you very much. I think with that we can wind up the second session and hear the final concluding remarks from Professor Shubin.
Okay, so thank you, Professor Duan. Today we have around 1,500 audience in the WeChat channel to listen this kind of very important webinar. Thank you both, Professor Tapa and Professor Duan.
Thank you.
Thank you very much. Now I'd like to wind this up officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaito. I would like to thank both the speakers of today, Professor Amit Thapa and Professor Duan Lian, as well as the chairs, Professor Hidehito Kimura and Professor Shubin, for the time and support for the ACNS webinars. I would like to express my sincere gratitude, Professor Shubin, for broadcasting this on the WeChat channel. And as he said, there are around 1,500 people who have joined us live. A special thanks to my co-host Liu Bun Seng for joining me today. So until we all meet next week, it is bye-bye from all of us. Thank you very much for joining. Bye-bye.